Good morning, Dr. Rachel Shmuts. I'm so excited you're joining me today for our podcast recording with Misconceptions, my new podcast. Welcome.
Thank you. Thank you for having me.
It's always fun to be able to schmooze with friends and chat and talk about these important topics. I feel like you and I tend to find time to do these things anyways, but especially to put it out there on a more public forum. I know exactly what kind of quality this podcast is going to be and what great information we're sending out to the masses. So thank you for being a part of our conversation today.
Of course, anything for you.
Thank you. Okay, so Rachel, tell me, you are what we would consider a perinatal or reproductive psychiatrist. Why don't you tell the audience, what does that mean?
Okay. I think I prefer the term reproductive psychiatrist because it gets the whole spectrum. And so reproductive psychiatry is a field of medicine. And so I'm a psychiatrist. I prescribe medicine. I do medical workups that really focuses on the psychiatric manifestations and life changes that happen around the female life cycle. So, people have emotional behavioral changes or disturbances or dysfunction around their periods, or what we call menses, around not just around pregnancy, but about preparing for pregnancy, family planning, infertility, the pregnancy itself, postpartum, and also around perimenopause. So I see patients, I can say I'm also a perinatal psychiatrist because I'd say, 80% of my patient population are around that, before the pregnancy, after the pregnancy, during the pregnancy. But I do see quite a few people who are experiencing other things around female life cycle events, either, mood disturbance around their periods, around perimenopause, post-hysterectomy, post-cancer surgeries, if it has something to do with, the female organs, and sort of everything in between.
So why do you think that we needed this own terminology? Why, this is not something that existed 50 years ago. I don't think the term reproductive psychiatrist, but why do you think that our world has shifted into really, I believe in it. Why do you believe in the need to have this subspecialization? Because really, if you want to become a reproductive psychiatrist, there's very few formal fellowships. There isn't a board certification that goes along with it. Why is it necessary? Why do we need this subspecialty?
I'll say there's no board of certification yet, but we're all kind of pushing for it. I think it's extremely important to understand with the women's health and women's mental health population is that sometimes psychiatric and illness does not manifest the same way in women than it does in other genders, and that there are very special circumstances that are very specific to the female life cycle and to the biological changes that happen in our bodies and in our brains that are not comparable to what it happens in men. And so it's really, really important to understand what the body and the brain are doing in order to understand the physiology of it and what we call the semiology of it, what it looks like, how it feels, in order to target the right treatment. And so, there are some treatments out there that we use now. There's actually two that have been FDA approved that are only for postpartum depression and not for any other kind of depression, because finally, and this is kind of hot and new in the field, we've been able to create treatments that actually target the underlying biology and physiology of the disease that's very specific to that female life cycle state. And so it's really important that we're aware of all the different contributing factors that may be very unique to this population and address treatment from all of those standpoints. I hope I answered your question.
You did. No, that's great. And I think the other thing that is maybe even on a more simplistic level is that I think historically we've absolutely seen where the woman becomes pregnant and the OBGYN says, just get off all your medications because I don't know what to do with medication in a pregnant woman. And then she would go to the psychiatrist. Psychiatrist would say, I don't know what to do with a pregnant woman. And I'm not willing to treat somebody who's pregnant. So there was this kind of,
I would say that's not even historical. It's still happening very, very often, hopefully less often than it used to. I'll take it one step further and bring it or take it a little bit broader. And that for, women and females are considered a marginalized population in research. So, as far as it's really important for us to understand how to treat people with a dearth of research that we have, because pregnant patients are almost always excluded from the high standard trials and experiments and stuff with drugs. And so we don't have a lot of data. The data we have is expanding and it's good, but we have to understand that, that's because we haven't actually even studied this population. We're just now, like, the culture is just now coming around that we need to actually look at really, really high quality studies in this population, from which most of these patients, particularly the perinatal patients, have been excluded for the last 50 years.
And those perinatal populations are primarily going to be retrospective studies, right? Nobody's
Most of them are
establishing
retrospective,
studies.
and most of them are
Right.
very small.
Right. So,
Yes.
so just to clarify that for someone who might not be familiar with that research term, is like retrospector, meaning like we're looking back at how these patients did. We're not really able to do these randomized controlled studies, right? Is that the proper terminology, right?
Randomized controlled studies. They're considered the gold standard. And I don't know if you want me to go on a tangent here, but like, they're considered the gold standards for medication safety evaluation. And the issue with that is that in perinatal patients, you can't, what those look like essentially boil down to like very, very brass tacks, is that you have a group of people who are certain demographic, certain disease state, and then you have another group of people that are matched for everything as well, and one gets a placebo and one gets a drug. And then the people observing and taking down the data from the trial don't know which medication or which placebo went to which group. And then after a certain period of time, all is revealed, and then they look and see. It's a way of trying to eliminate bias. So it's called randomized controlled blind or double blind, meaning the participant doesn't know what they're taking and the observer doesn't know what they're taking. You can't do this in the perinatal population because giving a placebo is considered non-treatment. It's unethical to not treat a pregnant or a postpartum person. And you can't give them an unknown substance that might cause a whole lot of harm. And so rightfully so, perinatal patients are excluded from these trials. But then what? We still need to have information. So most of the information, like you said, is based on case studies where they look at 1 or 2 cases, or maybe even 10, 15 cases from old charts, and sort of pulling the data and trying to make a story of it. That's most of the information. There are, over the last, I'd say 5 to 10 years, what we're doing, particularly out of Mass General and other really well-funded academic centers, they're calling for people to come into registries where they're going to say, okay, you're pregnant, you're on this med, we're going to watch you and we'll gather all that information. And those are prospective, looking forward. Those are more powerful and have more information. And the more people that get involved in that, the more information we'll get, the better what we call the power of the study, meaning the more meaningful the information. And so we're really, people in the field are really working hard on trying to get that kind of data, and more is coming out every day, which is really wonderful, but still not enough.
Right. Why is it considered unethical to not treat a pregnant woman? Like, I'm curious,
So
would it be unethical to just not treat anybody who's suffering from a mental health disorder?
Of course. But I think we can really go down the philosophical rabbit hole.
I'm just curious.
I think the idea is that not only is there just a person who is consenting to the possibility, everybody has to consent to these trials. This person who may end up on the placebo is consenting to the fact that they know they may not get the experimental drug, and then that's kind of on them. Whereas a pregnant person can consent, but the fetus is the issue, right? It's sort of forcing non-treatment on an entity. If we're really getting into the weeds here, but
it's interesting.
Who can't consent. And so that's where a lot of the debate comes in.
It's so interesting. So I also hear you saying, like, I can consent to choose not to get treatment.
Yeah.
There also
or the possibility
of me not getting treatment, but then I also have this baby that also will now be exposed to illness potentially. So they're exposed to medication, but they're also potentially exposed to illness. And
that's
obviously we're working
the bigger point. Yeah.
Right. And we're actually being, and that really is an excellent way for us to begin to this discussion about how we look at medication and pregnancy. So the idea of a fetus being exposed to illness, forget the consenting part, but for now, but the idea of the baby being exposed to illness, we are recognizing that in a very concrete way, exposure to illness is not, as you say, benign. Now, I want you
Right.
to explain that's a very medical term.
Yes.
Let's talk about what that means from a psychological perspective. So we have a woman who has depression or anxiety. She's diagnosed with depression and anxiety. She goes to her doctor for treatment, and the doctor says, I'm going to give you medication, and this woman is pregnant. Okay. And she says, no, I don't want to take any drugs because I'm pregnant. I want to do this without medication. Talk to me about how we then assess the exposure to medication or the risk of exposure to medication versus the risk of exposure to illness. And let's start with illness. What do we know when a fetus is exposed or baby is exposed to illness of a mother, a mental health illness of a mother? What do we know?
Great question. And this question is actually probably the most important question, because this is the part of the conversation that people who aren't familiar with working with this population are either unaware of or don't feel equipped of talking about or minimize. My experience is then with physicians or other providers who don't, again, have familiarity or extra training when working with this population, is that part of the conversation is I don't know why sorry, you may have to edit this out. My AirPods decided to kick in again.
Kick in. Yeah, I just lost your audio.
Hold on, I want to my mouse isn't working. There we go. Can you hear me or no?
I can hear you now. Yep.
Okay. So I'll pick up where I left off. So so what do we know? We actually know way more about what illness can do to a pregnancy and the health of a pregnancy than we know about the medicine. So when I said before we don't have much data on the medicines, that's true. Because we don't have much data on medicines and so many people sort of suffered for so long and do go through these pregnancies with active symptoms, we have a lot of information on that, and it's kind of not debatable, right? So what information is we know is that first and foremost, a lot of people are actually most worried about postpartum, right? We don't even give it a second name. Women were walking around saying, oh, I had postpartum, or I'm afraid of postpartum. Postpartum what? What we know is that, what they're talking about are postpartum mood and anxiety disorders. There's other more rare, severe forms of illness that are a little bit different than that. We can talk about that if we want to, but what we know is that 50% of postpartum mood and anxiety disorders actually are happening during the pregnancy, start in the pregnancy. And I think that number is probably even higher. So treatment during the pregnancy will help mitigate or even entirely prevent a postpartum episode. So one, it's an anxiety, and some people say, well, I'm not depressed, I'm just very anxious. Antenatal or pregnancy related or anxiety during pregnancy doesn't need the depression in order to cause a depression later. It's an independent risk factor for postpartum depression. So I say it doesn't matter, you're anxious and not depressed now, it's still something that can affect you later and get worse, and with the sleep deprivation, everything like that. We know that women who are actively depressed and anxious during pregnancy have a higher chance of less attention to prenatal care, more missed appointments, more missed ultrasounds. In efforts to sort of self-medicate, there's a common misconception that prescription drugs are more dangerous or more risky than over-the-counter medications, and that's simply not true. So what people is that if they're not sleeping because they're super anxious or depressed, they may reach for the over-the-counter sleep aids and overuse them. People experience more pain when they're depressed and anxious, so they may be overusing Tylenol or other painkillers during the pregnancy, and they say, no, it's okay, it's okay. It's not okay. Those things have risks as well. Women who may or may not actually have a history of substance use tend to relapse during pregnancy because of the stress and the negative emotional state. Higher risks of returning to alcohol use, smoking, marijuana, all those sort of things. Depression and anxiety are very stress related, very stressful states. That increases the stress hormones in the body, and that there are other pregnancy related diseases that could be made worse by being already stressed because of anxiety and depression, including gestational diabetes, gestational hypertension or high blood pressure of pregnancy, preeclampsia, which are all very dangerous and definitely need medical attention urgently, and careful monitoring. There's higher rates of loss of productivity, just like somebody if they weren't pregnant, depression, anxiety, and functional problems, loss of job. More women lose their jobs than men during, high stress states and other things. Higher rates of domestic discord and violence to pregnant women as a risk factor, loss of social support. We also know that there are risks with medications, but some of the risks with medications are kind of the same risks or risk factors that we see for untreated illness, like early labor, potentially smaller babies, babies having trouble adapting to life outside the womb. And so, higher risk of operative delivery, including vacuum-assisted forceps, C-section. So these are not nothing. And so these are the conversations that I have with patients when they come into my office looking for care.
So I'm going to summarize what you just said, because I want to bring it down to the basics, which is that untreated mental illness, untreated depression, anxiety, any of the other things that we work with, if we do not treatment, there is direct, clear risk to the mother and potentially and to the baby as well.
Yes.
And our job is to say, okay, so if we are comparing that risk, the risk of untreated illness, we are now going to compare it to the risk of medication. Talk to me about what are the risks of taking medication. And I think it might even be valuable to say, why don't you first tell me the risks of taking Tylenol, right? What are the risk factors associated, or the risks associated with taking Tylenol in pregnancy, which most of us would do? We have an ache, we have a pain, we have a headache, we're going to take Tylenol. So we have the risk of Tylenol versus the risk of an SSRI, a Prozac, a Zoloft, something like that, that might be more familiar with some of, the medications that our audience might be familiar with. What are we compare? We are now going to compare the risks that you just outlined of untreated mental illness versus the medication risk of taking these medications during pregnancy.
And so it might, in some cases, it depends on the medication. I'll say in most cases. But if we're talking about depression and anxiety, most of the medications that we're using are the SSRIs, or the selective serotonin reuptake inhibitors. They're antidepressants that have been around for quite some time. I think Prozac is the oldest one, been around for over 40 years at this point. And there's a few newer ones. And of course, the older the medicine, the more information we have on it, because it's been around longer. But I'll kind of focus on that, because there are a handful of other medications that we use for other mood disorders, anxiety disorders, and psychotic disorders that might carry more risk individually. But with few exception, that does not mean that we cannot justify their benefit versus the risk in pregnancy. I can talk a little bit about one or two of them, but honestly, with rare exception, most medications can show a benefit. And if there's a benefit versus a risk, so it's a three-part thing, and I'll get to answering the question shortly. There's a three-part conversation, or a three-part consideration here. It's the benefit of medication, which, is improvement, wellness, remission, symptom-free, which is always the target for treatment, versus the risk of the medication, either as a class or as an individual medication, versus the risks that we just talked about. It's never just a benefit versus risk analysis. It's a benefit versus risk of untreated illness. And without that last part of the conversation, there can be misconceptions and misinterpretation of just the first two parts of that conversation. So going to the potential risks of, generally, we're talking the SSRIs when we talk about depression, anxiety, and pregnancy. What we know based on, and we do actually, compared to a lot of other medications, we have the most data on the SSRIs. So this is fairly valid, it's pretty valid information. We know that the SSRIs do not appear as a class to increase congenital malformations, meaning organ malformation with exposure in the first trimester. There's been talk in the past about Paxil or paroxetine, about potential heart defects, but that data actually hasn't been replicated. There's other reasons I don't love Paxil, which is another podcast, but if somebody is on it and they're benefiting and they're doing great and they want to get pregnant, I wouldn't necessarily change it because of that risk, because the risk is really unclear. But as a whole, what we see actually in the general unmedicated population of people having healthy, or what we would consider healthy pregnancies, the rate of congenital malformations is 1 to 3%. And then about 70 or 75% of those, we have no idea why they happen, probably because of chromosomal abnormalities, genetic issues, but really we don't know. So that's huge. What is it with the SSRIs? 1 to 3%. So we have really good documentation that these as a class do not increase risk for particularly heart defects, but other organ formation. And a lot of people are very nervous about that. The other thing, and we also think about things as times of critical exposure periods, like, is it different risk based on first trimester exposure or second trimester exposure versus third trimester exposure? So I just talked about first trimester exposure because by the end of the first trimester, all the organs are sort of formed and closed. The brain continues to develop through about 25 years of life, and that's also another conversation. But at least the structure is closed, and in its cases, it should be by the end of 12 weeks, 12 or 13 weeks. So then second trimester, there's not a whole lot that we worry about as far as the SSRIs are concerned. Brain development is very, very active during that time. There was a question, and there's been a lot of things in the literature about higher risk of autism sort of being that's the critical period of that. And it's been completely refuted and debunked. So as far as we know, that's not a relationship, not correlated with the SSRIs. Third trimester exposure is actually where we have this is where the bulk of the conversation occurs. What we here's another important thing to talk about is the idea of causation versus correlation. Is that causation is A leads to B, it's not the other way around, it's this one and this one, and it goes in one direction. But correlation can mean that these things run together and we're not sure if they're causing each other, or if there's a third thing that might be going along with it as well, which we call confounding by indication or confounding, but that there's some maybe relationship there, and we don't know that much, but that's what there is. So what we find is that there's a potential correlation with the SSRIs with a couple of things. One thing, it might be early labor. Now, what does that mean? There's an idea of this thing called preterm labor. Full-term pregnancy is considered 37 weeks. Most people will go longer than that, but anytime after 37 weeks is considered full term. Early labor might be just earlier than you were going to go. And what we found is that, okay, maybe there is some relationship with the SSRIs. However, it's on average 3 to 5 days. So if a person was going to deliver at 40 weeks and now they deliver at 39 weeks and 2 days, from a fetal development standpoint, there's no safety issue there. Now, if you were going to go into preterm labor and deliver at 36 weeks and then you deliver at 35 weeks, that actually might make a difference. But, we really just don't know. There's also a correlation of the SSRIs with something that has multiple names, and they're all sort of mean the same thing, and we're smiling because she knows what I'm talking about, but it's called, I like to go by poor adaptation syndrome, or neonatal abstinence syndrome, or neonatal withdrawal syndrome, which is a misnomer in some circumstances, or something like that. Essentially, it's a non-specific, pretty benign condition where babies who are born full term, whatever, doesn't matter necessarily, although there are higher rates of this in earlier and preterm babies, where they just have trouble getting used to life outside the womb. Their muscles might be a little twitchy, or they might be a little softer than they should be. They may be extremely irritable, although I tell my patients, like, I've never met a newborn who's not irritable, but maybe extra irritable. Might have trouble latching, might be a little shaky, might have some jaundice is not part of the picture, but that's also very common. There are severe cases that are extremely rare, and in my clinical opinion, usually something else was going on or something else that may have contributed to that. And what happens is that, it could be a difficult couple weeks. It's often so non-specific and mild that it's not even recognized. A lot of it's sort of just pawned off as, newborn. And usually, sometimes these babies need to go to the NICU for a day or two for just observation, usually not really intervention. And the symptoms sort of revolve and they become a normal, sleepless baby who's always looking to eat. And so, really it doesn't have a whole lot of clinical not basis, but like clinical significance, in so much also that babies who are diagnosed with this, there's been studies looking at them at 6 months and a year postpartum or 1 year of life, and neurologically they're completely normal, intellectually, and all meeting their milestones. So this is considered a transient benign condition. There's one other thing to talk about called primary pulmonary hypertension of the newborn. What that is that with, again, correlated potentially with SSRIs. And then I have a big asterisk at the end of this section of this talk, which I know Devorah knows what it is. But this is something that is a little bit more serious. Essentially, babies are born with elevated lung pressures, which can cause some strain on the heart. When this is recognized, and it's often when it's recognized. Babies usually require some supportive care in the NICU. It's treatable. In very rare circumstances, is it fatal? And it happens in less than 1 in 1,000 exposures. Not in less than 1 in 1,000 babies, but less than 1 in 1,000 exposures. Years ago in the early 2000s, there was a class action lawsuit that was naming this as an issue. And in 2011, the FDA actually came out and said, yes, we recognize this as a potential risk. However, it's not thought to be more of a risk than to change, your care of a patient. And so use clinical judgment. They never say that. The second they see something on a drug that they pull it from the market. So they for them to say, okay, we see it, but these are really good medicines and they treat a lot of people. So just make sure you give informed consent and you're going to go from there. Another very, very more common risk for primary pulmonary hypertension of the newborn, just to give you some comparison, is C-section. So how often is C-section, right? So, we compared to that, it's so much more rare. The big asterisk, and there's some more stuff, but this is the highlights. The big asterisk here is that it's, again, correlation. So we don't always know if it's due to the med or the reason you're on the med. And it's, again, confounding by indication. Is it the medicine or the reason you're on the medicine? For some reason, it's easier for people to grasp this from a different perspective with a different medical disorder. So I use diabetes very often, right? Is it the insulin or is it the fact that you have diabetes? Or hypertension. Is it the high blood pressure or is the medicine treating the high blood pressure? That just seems to be an easier concept. And so do we sometimes see, so newer studies are actually coming out really trying to control for that. And it's very hard to evaluate that in these studies where we're just kind of looking at gatherings of people on medicines. You can parse those out in randomized controlled trials, but not on the observational trials. We're just looking at people, especially going prospectively. And what we're finding is that some of these risks persist even if someone isn't on the medicine. So could it be the disease? Could it be the medicine? The answer is it's probably both.
I think what's really powerful in these conversations is also recognizing that when we're talking about mental health, we are talking about a disease. And I think that's one of the areas of real deep confusion or conflict when, you are a medical doctor who is treating a medical illness, you are treating disease. And I think what's so complex about that is if I go for a blood test, I can't measure my depression. I can't measure my anxiety. I cannot have a test that tells me, oh, your blood pressure is this, right? When I go to get my blood pressure tested, I have high or low blood pressure. And yet we do not yet have testing that tells me, oh, actually, your depression is at a level 6 or a level 8 or level 10, or you have these markers in your blood that show me that you have depression and anxiety. And I think that's part of what we're so deeply challenged with in this field of psychiatry in general, is because it is so difficult to measure it and to prove I have it other than by my actions, my behaviors, my feelings, and what I express to you. Sometimes it can feel so invalidating, or is this very real? Or go back to that original comment we always hear of I should just be able to get over it. I should just be able to pull myself together. Let's talk a minute about the shame that comes along that so deeply kind of underpins so many of these decisions about taking medication or not taking medication. I think what we're always fighting against is the shame piece of, or the guilt piece of, I needed to do this. And it's based on my own report. It's not something I got a blood test that confirmed I do indeed have this diagnosis. What are you
Mhm.
seeing in the women you work with?
I see a lot of guilt and also shame. So which they're very connected, but slightly different. Guilt is a much more sort of internal sense, and guilt will like push you to confess, right? Like, but shame causes you to hide. It's not, it's feeling guilty, but then also worried about what other people will think. That's the shame piece. I've had a lot of patients come in and say like, am I a bad mother for wanting to be on my medication? Because sometimes they have a history of depression and anxiety, and they've really suffered and they've really benefited from their medication. And then, they get pregnant and some provider, says you need to get off of it, or I won't prescribe this for you. And it makes them feel so helpless and isolated and alone. And, the dog. Sorry.
I don't even hear it. You're
Oh,
good.
okay, good. Isolated and alone, and but they know they want to be well. So like they're kind of hearing, from authority, our authoritative sources, like no, 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 but they want yes, yes, yes. And then they say, well, am I bad? And there's this sense of like that taking particularly psychiatric medication during pregnancy, and that stigma is tied to your moral code, right? But I say to them, I said, but what if you came in here, and I'm nice about it, of course, but I'm like, what if you came in here and your blood pressure was 250 over 100? And I said, let's give you a beta blocker right now. Would you refuse?
Would you question it? Right.
Would you question it? No. Well, why are you questioning this?
Right.
So I try to sort of, I'm constantly using the disease analogy, because really it's no different. Having high blood pressure during pregnancy can give you some of the same risks as having depression. And depression can contribute to high, getting there. But like, so I see that. I see, am I bad because I want this? I've had patients ask, do I have to tell anybody? Do I have to tell my partner? Do I have to tell my husband? Do I have to tell,
My
does
mother-in-law, my mother,
know about
right?
this? Like, so like this idea that like it's a secret, it's something to be ashamed of. And there's a lot of I do a lot of most of what I do is men management, but I'd say in like, if it's a half-hour follow-up appointment or an hour intake, 45 minutes of it is this conversation. It's easy to pick the med. It's easy to figure that out and talk, but it's this, like, you are, this psychoeducation, this validation, and in some ways normalization of wanting to be well.
Right. I think about it, like, I think also about why we would, and I think it's a very much a female driven issue. So I think we're worse about it, of like, I'll just like, if there's any risk, then I'm just going to white knuckle my way through it. Lee Cohn always uses that terminology, that risk of like just white knuckling my way through it. Dr. Cohn from Mass General. And really, why does a woman feel like she should need to be suffering? And I have yet to find anywhere in our commandments and our mitzvot and our Jewish law where it says that that there is a mitzvah in the suffering, that there is a commandment to suffer. I haven't found it yet. There's a lot of suffering, enough to pass around, but the suffering is not is not something that we should be seeking out, or like there's something valuable in the suffering when we're
You don't
talking
get
about
a
these
medal. I
issues.
tell them you don't get a trophy for it.
That's right. I used to say, it doesn't say it on my tombstone that I did not have an epidural. Like, it's just not going to say it. And that's really, that made me feel a lot better when I had my children, there was a strong sense of like, well, are you going to have an epidural? You're not going to have an epidural. And I think perhaps the conversation has shifted a little bit 20 years later, but maybe not enough. But there's still that sense of like, to be natural is the ideal way. And I think to be healthy has to become the ideal way, and to making sure we elevate this, like, the value of wellness. And if you think about it, if mom has the flu, right? Mom is not, and flu is temporary, it's a week, hopefully no longer, maybe
Mhm.
less. A week is and mom has the flu. Trust me, even in a wonderful egalitarian home, there's laundry that is not done. The kitchen looks gross. The kids' homework may or may not have been completed. She's not able to do her job if she has one in addition to outside of the home. And yet, when we talk about mental illness and we talk about depression and anxiety, there's this expectation that she'll be able to do that and all her jobs, even if she's unwell. And I think we have to begin to honor that wellness should be a value,
Mhm.
should be honored, and should be one that that needs to be is so important to hear the voices to make sure she's not suffering and to make sure,
Right.
because and we'll kind of come to the end of the conversation here, but because you and I could talk for hours. But I
Mhm.
will say that, one of the things that I love when I speak to my students, and I'll say to them, when I teach for Wurzweiler, and this our Schneer program, they'll say to me, "Oh, I only want to work with kids. I wasn't sure if I should take your class." And I'm like, who do you think the mothers are of the children that are struggling in kindergarten and first grade? Ask them what was going on or what is currently going on at home. Did mom just have a baby? Is mom dealing with depression and anxiety? Is mom postpartum, and really having a hard time of it? Those are the kids you're dealing with. So can we please look at it as a family related issue? This is a family problem. Rachel,
Mhm.
let's conclude, if you don't mind. What
Mhm.
are some of the top misconceptions that you want people to know relating to reproductive mental health?
The top misconception, I would say, maybe you can agree or disagree, is that depression and anxiety are not normal occurrences during pregnancy or postpartum. I don't want to hear people say, "Oh, you just had a baby. You're supposed to be sad. You're supposed to cry. Everyone cries. You're hormonal. Oh, you're not supposed to sleep. It's supposed to be hard. You're supposed to just push through."
So the
Depression,
misconception is that it's normal to
that
feel
it's
this way.
normal.
Yeah.
I had it. My sister had it. We all were fine. Depression and anxiety are never normal. Like severe anxiety. I'd argue that some anxiety is motivating. We all are a little neurotic. That's how we function. But debilitating anxiety is not normal. Depression is never normal. And so if you feel, and I get this from so many women, and oftentimes they'll come to me, sorry, the dog's barking. They'll come to me after they're with their second or their third pregnancy. And with the first pregnancy, they clearly had postpartum depression. And it was either they never said anything because they thought, this is the way I was supposed to, this is the way everyone feels. This didn't, but I always knew something was wrong.
Yeah.
And they'll say, I pushed through, I didn't tell anybody, or they did tell someone and it was dismissed. But there's always that, but something was wrong. It
Yeah.
wasn't right. No matter how many times people told me it wasn't. And then they come with their subsequent pregnancies or postpartums, knowing what to look for and knowing that they don't want to go through that again. It's never normal to have postpartum depression and severe anxiety. Yeah, that's what I would say the top misconception is. And the second one, from my perspective, being a prescriber, is that the biggest one is you can't be on your meds during pregnancy. Wrong. If there's a benefit versus risk, a favorable benefit versus risk analysis, which 99% of the time I'd say that there is, especially if someone has a history and they're on a medication and it's working, then you can be on you're allowed to be on your medication during pregnancy because you're allowed to have wellness. You're allowed to be well and to want to be well during your pregnancy. I tell women all the time that, like, if you're not well, the pregnancy is not well. If you're not well, your
Yeah.
partner's not well. If you're not well, your workplace isn't well.
Right.
You're so important to the systems that you built around you, and they
Sure.
are going to be sick too. And I don't mean to impose guilt, but they need to realize that it's not all about the fetus or the baby. It's about them, because without them, there are no pieces of the puzzle that fall into place.
Right.
And so that's important for them to hear. So you can be on meds during pregnancy, and depression's not normal. I'll
Excellent.
say those encompass a lot.
They do. They really
Yeah.
do. And I think that you deserve to be well. It's not just that you can be well, you deserve it. You deserve to be well. I would like
Yeah.
to put in a plug for reproductive psychiatry. I think it is crucial that if your prescriber, your OB or your midwife or your family doctor says, no, 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 you can't be on medication, these are the experts that you should be asking to see. I would say a lot of our OBs are doing so much better. They're getting training. They're
They are.
learning how to do this. They really are getting better, and kudos to them for pushing themselves to learn and to be able to meet these needs. But if for whatever reason your prescriber is not meeting your needs, get somebody else involved. You're welcome to reach out to me. You can reach out to Dr. Shmuts, and we'll tag
Absolutely.
her information as well to be able to, see an expert who can confidently and comfortably teach you about what it means to be well, to stay well, because you really do deserve it. So,
And sometimes all it takes is a conversation.
right.
Sometimes I would totally agree the OBs are getting a lot better. But if you happen to have one that is just not informed and they're, sometimes seeing me once and then having me talk to them, or even just sending my report, and a light bulb can go on, and then they're on board. Right. So
Absolutely.
it's not even about, it's just about collaboration, interdisciplinary care, and educating everyone who's part of the care
Fabulous.
team, and building a care team around you of people that are
Absolutely.
comfortable with what we're working with.
Yes. And we're doing good work. You're continuing to do good work. Dr. Schmutz, thank you so much for spending some time with me, extra time with me. It's so appreciated. And I know that this information is incredibly valuable, and I know that my listeners will love it. So
Thank you.
thank you for
Thank you
teaching
for all
us.
you do. I think the world of you and everything that you
Thank
do
you.
as well. And I love collaborating and working with you.
It's always an honor. It's always an honor.